Welcome to Medicine Handy Point. Today we will discuss malaria treatment and prophylaxis. So, in chloroquine sensitive non-pulsiferin malaria is usually because of Vivax and OL. There are other species as well, but Vivax and OL are more important and common. So, it is treated with chloroquine in chloroquine sensitive area. So we start with 600 milligram base, then followed by 300 milligram base after 6 hours, followed by 300 milligram base on day 2 and day 3. This is the treatment for chloroquine sensitive non-falciparum malaria. This is followed by primaquine 30 milligram OD for 14 days to kill the hypnosid stage of Vivax and OL. These stages has to be killed because they are present in the liver and they can cause recurrent malaria. So primaquine should be given after giving dose of chloroquine, and primaquine can cause jaundice in G6PD deficiency patients. So make sure that the patient get G6PD test done before starting primaquine. Now, uh, in an area where there is chloroquine resistance, so we treat non-pulsiferum malaria as we treat it with artemether plus lumefantrine. We use atovaquone plus proguanil. We use quinine plus doxycycline. So we use either of one of this combination and followed by primaquine to kill the hypnosid stage. Now, uncomplicated falciparum malaria. In falciparum, there is a complicated form as well. So first we will treat the uncomplicated falciparum form. Falciparum malaria is treated as artemether plus lumefantrine with dihydro artemisinin plus piperaquine and quinine plus doxycycline. So we use one of these three combination for treatment of uncomplicated falciparum malaria. Now, malaria prophylaxis is very important in a patient traveling to the area where malaria is endemic. So if we are going to area where there is non-pulsiferum malaria is common, we can simply use primaquine. In an area where falciparum malaria is common, we will start prophylaxis based on chloroquine sensitivity in the area. In chloroquine sensitive area, we use chloroquine 300 milligram weekly base 1 week before the travel, then we will use it during the stay of the travel, and 4 weeks after the return. So in chloroquine sensitive area we use chloroquine. In chloroquine resistant area we use mefloquine 250 milligram per weekly 2 to 3 weeks before the travel, during the stay of the travel, and 4 weeks after. We can also use doxycycline 100 milligram OD 1 to 2 days before the travel, during the stay of the travel, and 4 weeks after the travel. We can also use atovaquone plus proguanil 1 to 2 days before the travel, during the stay of the travel, and 1 week after the travel. So this was the prophylaxis. Now, severe complicated malaria is usually caused by Plasmodium falciparum. It will have the following feature. It will have seizure or unconsciousness. It will have anemia HB less than 10. It will have ARDS. It will have shock. There will be hypoglycemia. There will be acute kidney injury. There will be metabolic acidosis. There may be parasitemia more than 10%, which is indication for exchange transfusion. There may be bleeding because the severe malaria can cause TAC. So we treat it with artesunate or quinine. Artesunate is the drug of choice because of less toxicity. Quinine can cause hyperinsulinemia leading to hypoglycemia and synchronism. Synchronism is tinnitus, hearing loss, headache, nausea, and vomiting, along with visual problems. So we prefer to use artesunate instead. I hope you like the video and please subscribe to the channel.